Tantor Audio, a division of Recorded Books, presents Parkinson's Disease, a complete guide for patients and families, 3rd edition, by William J. Weiner, M.D., Lisa M. Schulman, M.D., and Anthony E. Lang, M.D., FRCP. Narrated by Bob Souer. Publisher's Note: this audiobook includes bonus material. Please visit Tantor.com and type Parkinson's Disease, a complete guide for patients and families, 3rd edition, into the search box. Follow the link to the book's page. Then, under the Supplemental Content section, please enter the access code PARK, P-A-R-K, and then click the Unlock button to access the bonus material. The code should be entered in all lowercase letters. All figures, tables, diagrams, and charts referenced in this audiobook can be found in the bonus material. Preface. In the 13 years since the first edition of this book was published, much progress has been made in the management and treatment of Parkinson's disease. There have been important developments in understanding the basic causes of Parkinson's and the role of genes and heredity in this disease, advances in the role of surgery as a treatment, and the introduction of new drugs to treat symptoms. There has also been increased interest in research on disease-modifying or neuroprotective therapies that may slow the progression of Parkinson's. This new edition discusses all of these developments and retains the original intent and purpose of the book to help patients and their families develop a fuller understanding of what living with Parkinson's disease is like. When people first learn of the diagnosis of Parkinson's disease, they generally know little about this illness. Understandably, a myriad of questions arise. Many patients and families become alarmed as they translate their limited experience and knowledge to themselves. The fact is that the effect of Parkinson's disease on people's lives has been fundamentally altered in recent years, as new and better treatments have become available. Indeed, Parkinson's disease has become a disorder that does not prevent people from living productive and satisfying lives for many years. In fact, a large proportion of those with Parkinson's disease remain independent in the activities of daily living, ADL, 10 years after diagnosis. Understanding the symptoms of Parkinson's disease and the management of the disease is the key to each person's ability to preserve his or her sense of stability and control. There are many examples of medical conditions that are chronic illnesses, including arthritis, asthma, diabetes, and Parkinson's disease. In every one of these examples, the recipe for living well with the disorder involves having a clear understanding of both the medical condition and the pivotal role that a prepared individual can assume in the management of his or her own health. For example, in making clinical decisions, a physician relies on the history and feedback that the patient and caregivers provide. There is no one formula for the successful management of Parkinson's disease. Instead, success relies upon an individualized and comprehensive plan of care based on shared decision-making between the experienced physician and the prepared patient. We have written a book that explores Parkinson's disease in straightforward and honest terms. We have explained what goes wrong in the brain that leads to the disorder, and we have also explained how a physician goes about making the diagnosis of Parkinson's disease. We have discussed the subtleties involved in diagnosis so people with Parkinson's disease and their families understand the challenges that sometimes arise in arriving at a correct diagnosis. Parkinson's disease is a progressive problem that gradually worsens with time. In separate chapters, we have delineated the common problems associated with the early, middle, and advanced stages of Parkinson's disease. We not only discuss these problems in considerable detail, but also offer numerous suggestions based on our experiences regarding how to better live with these problems. Most people think that the major problems of Parkinson's disease relate to problems with movement, including tremor and walking. However, Patients with many years of experience with Parkinson's are also familiar with a wide array of non-motor symptoms, both due to the disease and its treatment. Therefore, we have a separate chapter, Chapter 6, in which we extensively review the common non-motor symptoms that may occur, including depression, apathy, anxiety, sweating, sexual dysfunction, memory problems, sleep disturbance, impulse control disorders, for example, excessive gambling, shopping, computer use, eating, bladder problems, and constipation. The role of drug therapy in the treatment of Parkinson's disease is thoroughly discussed in this book. In the last 45 years, impressive advances in the therapy of Parkinson's disease have been made. We outline how Parkinson's drugs work, why they are helpful, the side effects associated with them, and what patients can realistically expect of each of them. How to use medication safely and effectively, and the various drug combinations are also thoroughly reviewed, as is drug therapy for the various non-motor symptoms. The role of surgery in the treatment of Parkinson's disease continues to evolve. We review the different types of surgery that can be of value in Parkinson's disease. Importantly, we present the key questions that patients and families should ask themselves and their physician before considering surgery as a therapeutic option. The book closes with a long chapter of commonly asked questions and clear and concise answers to these many difficult questions that often arise during an office visit. The subject of each question and answer is covered in much greater detail in the many chapters within the book. Our many years of experience with taking care of patients with Parkinson's disease have taught us that well-informed, knowledgeable patients do better over time. Our goal in this edition is to contribute to a foundation of knowledge for persons who are living with Parkinson's disease in order to help them make healthy adjustments to these changes, to develop competency in self-monitoring and self-management, and to become effective partners in shared decision-making with their physician. The chapters of the book can be listened to in sequence, but they can also be listened to separately. To permit this approach, we have incorporated a certain amount of duplication in the information provided. For those listening to chapters in sequence, this can serve to reinforce the important issues covered. We thank all the patients and families whom we have taken care of over the years for sharing with us their insights, experiences, and responses to Parkinson's disease. The spirit that the Parkinson's community exhibits is an enduring inspiration. We hope that we successfully communicate the world conveyed by our patients to the larger community of persons and families affected by Parkinson's disease. We thank Cheryl Grant Johnson and Sharika Green, who have diligently supported us with fine administrative skills during the preparation of this book. We thank our editors, Jackwell and Waymuller of the Johns Hopkins University Press, as well as Alice Liam and Linda Strange, who helped us transform our initial text into an easily readable and patient-friendly format. We also thank special benefactors who have generously supported our research on this project, as well as many other Parkinson's disease-related projects: Rosalind Newman, Morton Schulman, Jack and Mary Clark, the Catherine Manson family, Lily Safra and the Edmund J. Safra Philanthropic Foundation, the Eugenia Brin family, and the Frederick Henry Prince Trust. Part 1. Introduction. Chapter 1. What is Parkinson's disease? What are the symptoms of Parkinson's disease? What causes these symptoms? What is the difference between Parkinson's disease and Parkinsonism? When should I tell people that I have Parkinson's? Whenever a diagnosis of Parkinson's disease is made, patients and families naturally ask, what is Parkinson's disease? As doctors treating people who have Parkinson's, of course, we discuss this question with many patients. But we, and they, are aware that the answer is both straightforward and elusive. Parkinson's disease is a degenerative neurologic disease. Degenerative means declining in quality. Thus, the disease increases in severity over time. Neurologic refers to the nervous system. One could therefore say that Parkinson's disease is a disease of the nervous system that gets worse over time. We also describe Parkinson's disease as a chronic, progressive neurologic disease. Chronic means of long duration. Progressive means proceeding in steps or advancing. Parkinson's disease does not go away, and it gradually gets worse. Parkinson's disease is named after the English physician, James Parkinson, who first described the illness. His original paper describing this disorder, published in 1817, was titled Essay on the Shaking Palsy, and to this day, Parkinson's disease is still sometimes called the shaking palsy. Ancient medical writings include descriptions of people with a disorder that fits the clinical picture of this disease, but Parkinson is given credit for providing the most thorough description of it. Another name for this illness is paralysis agitans, which is simply the Latin translation of shaking palsy. The names Parkinson's disease, shaking palsy, and paralysis agitans all refer to the same illness. There is some good news. True Parkinson's disease progresses slowly. Even after the symptoms have become clear enough to allow a definitive diagnosis, it is usually years, maybe 10 or more years, before a person suffers from a serious disability. Further, treatments are available that relieve symptoms so that years, sometimes a decade or more, can go by before symptoms have a significant impact on a person's quality of life. In people who have Parkinson's disease, specific groups of brain cells called neurons are slowly and progressively injured, then selectively degenerate or die. This process causes the typical symptoms of Parkinson's disease, which doctors call characteristic symptoms because they are the major features of Parkinson's. In this book, when we say symptoms are characteristic of or characterize a disorder, we mean they are typical of that particular disorder and distinguish it from others. These are the characteristic symptoms of Parkinson's disease. People who have Parkinson's may tremble involuntarily. They find their muscles become rigid and stiff, and they lose their ability to make rapid, spontaneous movements. They walk in a recognizable manner with a typical gait in which the body is bent or flexed, and they may have difficulty maintaining their balance. These symptoms do not emerge all at once. For example, walking may become slower and may not worsen for years. Balance is unlikely to be a problem until the more advanced stages, and tremor, the most recognizable feature, does not occur in everyone. The characteristic symptoms of moderate Parkinson's disease can be remembered with the acronym TRAP. T is for tremor and R for rigidity. A is for akinesia, meaning literally lack of movement, referring to the loss of spontaneous or voluntary movement and loss of fluid motion. The slowing down rather than complete loss of movement is called bradykinesia. P is for postural instability, which involves difficulties with balance and the risk of falling. Table 1.1. Parkinson's has neither a cure nor any treatment to slow down its progression. Furthermore, the signs and symptoms of early Parkinson's are only subtly different from those of other neurologic diseases, some more serious and some less serious than Parkinson's. The similarities among these diseases can make diagnosis difficult, and as frustrating as it may be for a person who has Parkinson's symptoms, often the only way to identify Parkinson's disease for sure is to wait and see. What happens in Parkinson's disease? In Parkinson's disease, neurons, nerve cells of the brain area known as the substantia nigra, Latin for black substance, are primarily affected, figure 1.1. When neurons in the substantia nigra degenerate, the brain's ability to generate body movements is disrupted, and this disruption produces signs and symptoms characteristic of Parkinson's disease: tremor, rigidity, akinesia, lack of movement or loss of spontaneous movement, and bradykinesia, slowness of movement, and problems with walking and posture. Other areas of the brain are also affected, especially later in the disease, and it is this aspect of the disease that likely accounts for the broad spectrum of symptoms that can eventually be a part of the illness. The symptoms of any brain disease are determined in part by the location of the neurons that degenerate. For example, Alzheimer's disease involves the degeneration of neurons of the cerebral cortex and results in memory loss and mental deterioration. In amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease, the selective death of motor neurons in the spinal cord and brain causes profound motor weakness. Again, in Parkinson's disease, the affected neurons are especially those located in the substantia nigra, an area of the brain that is important for control and regulation of motor activity, movement. What causes the symptoms? The substantia nigra is a very small area located deep within the brain. There is one substantia nigra on the right side of the brain and one on the left, but for ease of discussion, the medical literature refers to them as if they were a single structure. The symptoms of Parkinson's disease do not become noticeable until about 50 to 70% of the cells of the substantia nigra have died, because the human nervous system has multiple safety factors and redundancies built into it. For a long time, these safety factors are able to take over the activities of the dying cells. In autopsies of persons who had Parkinson's disease, the brain appears to be relatively normal, except that the substantia nigra has lost its usual black pigment, figure 1.2. Under the microscope, we can see substantially fewer cells in this substantia nigra than in that of healthy brains, and the remaining cells often show signs of abnormality. One hallmark of Parkinson's disease is the presence of small bodies known as Lewy bodies within the remaining substantia nigra cells. The substantia nigra accounts for an extremely small percentage of the brain's weight, but because of its important electrochemical connections with motor centers, brain centers that control movement, it is a vital component in how we move. Specifically, a series of complicated electrical and chemical events within the brain transmits information from neuron to neuron. The chemicals that brain cells use to communicate with one another are called neurotransmitters, or more generally, neurochemicals. The specific neurotransmitter produced and used by the substantia nigra is dopamine. When the cells of the substantia nigra degenerate and die, dopamine is lost, and dopamine-relayed messages to other motor centers cannot go through. This is the primary cause of most of the motor symptoms in Parkinson's disease. Recent technological advances in imaging techniques allow visualization of the dopaminergic cells in the substantia nigra in the living brain, figure 1.3. Several different types of imaging can be used, including positron emission tomography, PET, or single photon emission computerized tomography, SPECT. These techniques combine biology, pharmacology, computerized systems, and special laboratories to make radiopharmaceuticals that can be injected in patients and seen during imaging. One test that is now available is SPECT. A particular type of SPECT scan is the DATScan. Although this test can distinguish normal from abnormal dopamine pathways, whether or not it will be helpful in diagnosis remains to be seen. We will discuss the advantages and disadvantages of this test in Chapter 8. There is more. While the loss of dopamine-producing cells is the primary neurochemical disturbance in Parkinson's, the neurochemical disturbances are not limited to the cells of the substantia nigra and to the loss of dopamine. Other small nuclear centers within the brain, for example the regions called the dorsal motor nucleus of the vagus and the locus ceruleus, also are affected by the degeneration. In Parkinson's disease, as the concentrations of dopamine in the brain decline, so do concentrations of other neurotransmitters such as norepinephrine and serotonin, although changes in these other neurotransmitters are not nearly as significant as the loss of dopamine. These neurotransmitter and cell changes are spread widely throughout the brain, which may help explain why dopamine replacement does not correct all the problems caused by Parkinson's. For example, dopamine replacement is very helpful for slowness, bradykinesia, and rigidity, but generally is not helpful for balance. In short, Parkinson's disease is not just a dopamine deficiency state. Although we have some understanding that neurochemical disturbance causes the symptoms of Parkinson's, we still do not know what causes the neurodegradation, although extensive scientific research has been conducted in this area. For this reason, the disease is sometimes termed idiopathic, cause unknown, Parkinson's disease. In Chapter 2, we discuss what the current research indicates, and in Chapter 18, we investigate some leads that may shed light on the causes. Because the brain's neurotransmitters, especially dopamine, are so important to the central nervous system's control of the muscles, when these neurotransmitters are in short supply, the muscles act strangely. The central mechanism that controls muscle tone is altered. The muscles may tighten up at inappropriate times. Rapid tightening and releasing of muscles produces a tremor. Sometimes the muscles tighten up and become stiff and rigid. With inadequate communication between the brain and the muscles, movement also becomes slow. Muscles cannot make quick, fluid, spontaneous movements. The central mechanism that controls muscle tone does not function adequately for the delicate interplay of muscles required to help us stand, walk, and balance. In addition, because Parkinson's disease also affects the autonomic nervous system, the largely unconscious system that controls our body temperature, digestive system, sexual function, and bladder control, among other functions, these systems may also act oddly. In true Parkinson's disease, the first symptoms differ only slightly from the normal state and progress slowly, perhaps over decades. Different people have different combinations of symptoms. Parkinsonism. Any person who has the signs and symptoms characteristic of Parkinson's disease, tremor, rigidity, slowness of movement or loss of spontaneous movement, and postural impairment, is said to have Parkinsonism. But not every person who has Parkinsonism has Parkinson's disease. Parkinsonism has many possible causes, and Parkinson's disease is only one of the possibilities. For example, Parkinsonism may be the result of a stroke or a side effect of certain medications. Many other types of neurodegenerative disorders result in Parkinsonism, although Parkinson's disease is the most common of these. In many cases, the Parkinsonism found in these other disorders is due to damage to the substantia nigra, and more often than not, the damage extends to other brain areas as well. People who have Parkinsonism may have symptoms of impaired movement, thinking, behavior, and other body functions, such as blood pressure and sexual, bladder, and bowel function, that people who have true Parkinson's are less likely to develop. Even considering such differences, Parkinson's disease can be very difficult to distinguish from other forms of Parkinsonism. Patients and their families need to understand Parkinsonism because some 20 to 25% of people diagnosed with Parkinson's disease will eventually be discovered to have some other form of Parkinsonism. Parkinsonism may look like Parkinson's disease, but over time it does not act like it. Differences that were subtle at the beginning of a disorder often become more pronounced as it progresses. For people who have Parkinsonism, the symptoms may become more disabling more quickly or may progress more slowly than in Parkinson's disease. Parkinsonism symptoms may or may not respond to the medications used to treat Parkinson's disease. A number of other disorders that include involuntary tremor are not, strictly speaking, a type of Parkinsonism, but can also be mistaken for Parkinson's disease. If you have been diagnosed with Parkinson's, but observe that your symptoms are not characteristic of Parkinson's disease as described in this book, you may have another form of Parkinsonism or a different type of disease altogether. Table 1.2. What will happen to me if I have Parkinson's? Because Parkinson's disease is a progressive disorder, we can generally expect that each year the signs and symptoms of the disease will become more pronounced. With effective treatment, the symptoms may be so effectively masked that for some time it may seem that the disease is not changing, especially in the early years. Over time, however, even with treatment, most people who have Parkinson's do notice increasing problems. No one, not a physician or anyone else, can accurately predict how or how quickly the disease will progress in a specific individual. There simply is no reliable way to evaluate the degree of cell loss in the substantia nigra, no laboratory test or widely available imaging procedure that can tell us how much cell loss has occurred or how fast it is progressing. Even the new imaging techniques cannot predict severity or progression of disease. We can say that Parkinson's is not the kind of disease in which, within a 12-month period, someone who is able to walk and function independently suddenly finds herself or himself incapacitated and wheelchair-bound. In the average patient, the disorder is very slowly and gradually progressive over years, with relatively mild and subtle changes occurring in the first months to years of the illness. Although we can't predict how the disease will progress in a specific individual, we do try to answer the questions patients naturally have about the course of their disease. Why? Because people need to know how long they can expect to remain employed or fully self-sufficient. They need to know how their disease will progress for financial, employment, and social planning reasons. Disease progression varies greatly from one person to another. Some persons have a relatively rapid progression, beginning to experience significant physical disability within 5 years. Others do not reach this state of disability for 15 years. Sometimes these different disease courses are separated into benign and malignant forms. In our experience, most so-called malignant cases of Parkinson's disease have proved to be other diseases, which in their early stages were mimicking true Parkinson's disease. A person's history with the disease is the best guide to the character of his or her illness in the future. In other words, a person's disease usually progresses at about the same rate that he or she has already experienced. This means that predictions are particularly difficult for people newly diagnosed with Parkinson's disease because we have no information about how their disease has progressed so far. General information may be the best we can offer. In general, then, we say that when Parkinson's disease is diagnosed early and when medications are used judiciously, people may experience 5 to 10 years of motor symptoms that do not substantially interfere with their quality of life. Again, Parkinson's disease is not the kind of disease in which rapid deterioration occurs over a few months. Although we do not yet have treatments capable of slowing or arresting the progression of the illness, current treatments can very effectively relieve the symptoms, especially in the early years. As mentioned, many persons who are adequately treated notice very little or no progression of symptoms over the first few years. Although we cannot slow the progression of the underlying illness, patients benefit greatly because reducing the symptoms delays disability in Parkinson's disease. However, with time, a person's degree of motor disability does tend to increase, and after 5 to 10 years of illness, the symptoms generally begin to disrupt daily life. At this point, medications are needed in higher doses and must be monitored and adjusted more frequently. Treatment. Dramatic breakthroughs have been made in the management of Parkinson's disease, most notably the introduction of levodopa almost half a century ago, and subsequently the use of dopamine agonists and later deep brain stimulation. As noted, current treatment can significantly relieve people's symptoms, delay disability, and markedly improve their quality of life. Unfortunately, there is as yet no cure. Treatment is discussed in more detail in chapters 11 through 16. The first stage of treatment for Parkinson's is an accurate diagnosis. This is tricky, as we have noted, particularly early in the disorder when distinguishing Parkinson's disease from other diseases with similar symptoms is particularly difficult. It may be helpful to see a neurologist who is experienced with what are called movement disorders. A movement disorder specialist has expertise in diagnosing and treating Parkinson's disease and related disorders. A visit to a movement disorder center may also be useful. Most such centers are connected with a department of neurology at a medical school, although some are freestanding clinics. The centers have access to appropriate rehabilitation facilities and are usually involved in research studies. We believe patients' involvement in research studies is a good idea for several reasons. First, treatment of Parkinson's disease can be improved when people who have Parkinson's consent to participate in programs that test drugs, so there is an altruistic motive for some people. Second, in clinical research trials, new treatments are tested on patients in carefully planned studies designed or monitored by physicians and statisticians, and people in these trials might have access to helpful drugs years before the drugs are available to others. Finally, people who participate in clinical trials tend to do better than people who do not, even when the people in trials are receiving a placebo or sugar pill rather than a drug. This is because participants in clinical trials receive intense medical attention and monitoring. They are working with people who are especially interested in the...
Sample complete. Ready to continue?